Well, hello everyone, and welcome to Woundcare Pro with Nurse Practitioner Anne Walsh. Anne is a highly experienced nurse practitioner specializing in wound care, ostomy management, and palliative care with over 25 years in nursing. Anne holds multiple certifications and provides expert consultations for patients with complex needs. And she conducts wound care training for medical staff and has developed protocols to improve care outcomes. Anne is also a published author and legal consultant in wound care related cases. In 2022, she launched the educational app Woundcare Pro to address the shortage in specialized clinicians in the field. And we are so lucky to have her here each week to dive into different aspects of wound care. And this week we are talking about arterial ulcers. Welcome, Anne.
Thank you. Great to be here.
So it's very ironic. Before we started this session, you were saying you were just immersed in a case with an arterial ulcer. Do you want to share just a little bit and the frustrations around these arterial ulcers? And then we'll get into the basics.
Sure. Yeah, the particular lady came to us in June and had a tiny little area of black on the top of her left great toe. So, keep it dry, we could keep an eye on things. And it seemed to skyrocket. And the daughter was just so overwhelmed that I was doing consults remotely, but it wasn't enough. So I went there today to see the patient in person and, went from the toe, the great toe to more toes, half the foot, and then the other foot is turning black now. So, it's tough. The patient herself is 98, not really eating, sleeping more, so seemingly nearing the end of life, but very difficult for the daughter to see this, of course.
No, and you don't want to see someone suffer. And these arterial ulcers can be incredibly painful. So let's start with the basics. What are the defining characteristics of an arterial ulcer? In a previous episode, we talked about venous ulcers.
Right.
So, of course, regular ulcers versus venous ulcers versus arterial ulcers.
Yeah, so the arterial ulcers typically are on the toes, so the locations usually give away. Could be on the ankles or any other part of the foot or even the heel. So that's usually a telltale sign that, especially with the toes, it's like not many other types of wounds will happen in the toe unless, you're person may have diabetes as well. So it could be neuroischemic. So they may have neuropathy and ischemia. So you got the two hand in hand, but typically the toes and the feet.
And so you brought up diabetic ulcers. So diabetic ulcers versus arterial ulcers. I would imagine the difference between the two, at least internally, would be general arterial blood flow.
Right. And usually the diabetic foot ulcers are on the bottom of the foot, typically, where the person's walking and they don't have that feeling, they have the neuropathy, and the way they're exerting pressure, they may get a callus in the area, and all of a sudden it turns into an ulcer. So that's usually a telltale that that's a neuropathic or diabetic foot ulcer. Whereas the toes typically will clue in, say, okay, it's arterial disease. They could have all the above, of course, too.
So what are some of the diagnostic tests that are used to confirm the presence of an arterial ulcer?
So even in the home or in the doctor's office, they could do what they call ankle brachial index. They do the blood pressure in the arm and the blood pressure in the leg, the ankle, and compare. So it sort of gives a sense of if there's arterial disease there, or the person can go to a vascular office and get more complex workup, a toe brachial index, or this duplex ultrasound workup to really see what's going on with the blood flow.
I'm so glad you brought up the TBI, the toe brachial index, because I was just going to ask you, well, how
Yeah.
important is the toe brachial index and in these arterial ulcers, especially in the toes? And I'm so shocked that a lot of doctors still don't do them.
Yeah, I remember years ago, I'd go to the house and we had a Doppler machine available and actually do an ankle brachial index in the home for somebody who couldn't come out of the house. And we thought it looks like a venous ulcer, but before we went ahead and did compression therapy, we had to rule out there was no significant arterial disease.
So how should these arterial ulcers be cleaned and what products are actually recommended for this?
So just like with other wounds, you're going to use wound cleanser, maybe saline, nothing harsh, no harsh chemicals, even a mild soap and water, depending on the situation. And it'll be treated depending on the characteristics. If it's a dry, gangrenous area, that we're going to keep clean and dry and use betadine if the person's not allergic. If it's a cleaner wound, then we're going to look at maybe the antimicrobial dressings because the person's so at risk, like the honey products, the silver products. And if it needs to be debrided, we'll use a debriding agent. If it's not, like I said, intact eschar, those we treat differently, or dry gangrene, those we want to keep clean and dry.
Can you describe just how quickly these arterial ulcers can make a turn or take a turn for the worse?
Yeah, sometimes we see it's stable for a while, and all of a sudden, over the course of a couple of weeks, things move quickly. And we've seen that a few times. Even with this particular lady, she came on to us in our program in June, and we're in September now. I would say over the last week, it just seemed to take off. We did put her on antibiotics just in case and all that, but it just seems like the disease itself is progressing.
And when we talk about the disease progressing, we're talking about the blood flow,
Is that right?
and these arterial ulcers, healing really is heavily dependent upon whether or not the oxygen and nutrients can get to these wounds. But in these particular patients with arterial ulcers, they have what's called peripheral artery disease, which is those blocked arteries that restrict blood flow down to the lower extremities, especially into the feet and especially to those wounds. So, talk about the multidisciplinary approach to treating these types of arterial ulcers.
Yeah, and if the person's a candidate for some kind of surgery, then you could bring in the vascular team, and with the patients that I'm seeing in the home, there's a lot going on. We may bring in physical therapy if we're able to get them up, moving around. Get a home health aide in there to help. Get the social worker and physician and other medical group together to sort of help them. So it's all dependent on if they're still able to swallow, a medication. Sometimes we could add medications on, like antiplatelets or like aspirin, to try to help that blood flow get through. So it sort of depends where they are and what the goals of care are. But definitely, it's a team approach.
The interesting thing, we have so many advances in interventional, um, arterial tools, techniques, things like that to open up these arteries that I've seen even folks on palliative care actually have a procedure done in which the doctor um, does what they call pedal access, or they poke into the foot arteries and with the needle and or what they call the introducer, send some wires and balloons into those, small arteries in the foot and just open the vessel up to give the patient just that much more blood flow so that the wound can heal, or at the very least, they can get the patient out of the debilitating pain that this sometimes causes, right?
Absolutely, yeah. If they're a candidate for that, absolutely. You want to throw everything at them. Just the ischemic limb pain is so painful. So anything that could hopefully open the blood flow and help the pain is definitely worth trying, depending where they are in their life, and the goals of care.
And when it comes to the arterial ulcers, you were mentioning that, if they can't swallow, if they're maybe in a little earlier stage, the medications that they could take orally, possibly an antibiotic. But are there any other medications that are typically prescribed for treating arterial ulcers topically?
Topically, I mean, it depends on what we're looking at with the wound. Like I said, the honey products might be, anti-inflammatory, antimicrobial, that may help, ease any kind of pain from inflammation. And because of poor blood flow, they're at higher risk for infection, and the infection itself could, cause pain. And the silver gels are nice and soothing. Sometimes we could use I've heard of people use the topical nitroglycerin. I haven't personally, but around the wound, almost in a way to open up those arteries to get the blood flow. So there's a lot of topical treatments tried, but also systemic, taking in maybe aspirin or an anticoagulant or medication to help thin the blood a little bit and the viscosity. So hopefully the blood can get there through a narrow artery.
This is almost a rhetorical question, but I have to ask it. Is compression therapy appropriate for arterial ulcers, or is it contraindicated for the most part?
For the most part, it's contraindicated, but it depends on how extensive the arterial disease is. If it's mild based on the results of vascular testing, then they can tolerate compression therapy and it helps heal. But if it's like, a certain number below, 0.5 or whatever the cutoff is, then you can't use compression. But up before that, you may be a candidate for lighter compression. And there are compression wraps on the market that, give lighter compression versus the heavy duty compression if somebody had pure venous disease.
So when it comes to dressing, I'm jumping around here a little bit, but how often should arterial ulcers be, assessed and
Okay.
dressings changed? We hear a lot about these patients with arterial ulcers that they have a home care nurse that comes in once every few days and they tell the patient, no, leave it alone until we come back. But some people say, you know, I'm really afraid to just not open it. We had a patient in Michigan that went a couple days. She felt something funny in the dressing, and she calls us up and she says, Kim, you know what? They told me not to open it. But something feels funny. I feel like something's moving in there. I'm really scared. Kim, what do I do? And I said, you need to call the home care nurse immediately, or you need to go to the emergency room. And she went to the emergency room instead, which was a really good idea, because what do you think she
Maggots.
found in there?
Yeah,
Exactly. And she sent
yeah.
me this video of, I mean, it was filled. There had to have been dozens and dozens of them in there. And she was like, how in the world did these maggots get into my wound when it was wrapped so tightly? And that's still the, $1,000 question.
It is amazing. We even had a person the other day, and the doctor on the team said, make sure they close all the windows, because it was that type of a wound that she was fearing that it was going from dry gangrene to wet gangrene. And then she was thinking about flies getting in, and next thing you have maggots. But yeah, I've been surprised over the years too, that a dressing is on, good, wrap to keep everything intact, and you open up, there's maggots. Somehow those flies get in, and they could smell a wound from, hundreds of miles away, supposedly. If the wound is starting to soften and has an odor, that the flies get in there. It's incredible.
I mean, it still blows my mind. I
It
mean,
does. It does.
absolutely blows my mind. I mean, I don't know if they're landing on top. You wouldn't think that they could actually get in there, but maybe landing on top, and there's like a creep factor with
Yeah.
their eggs, right?
I mean, especially in the summer months, like there's more flies around and they get in there somehow. It's unbelievable. But, I try to tell people not to panic depending on the situation, because they'll clean the wound up oftentimes, and then we rinse them out with, peroxide or Dakin solution or something. But depends on the situation, of course.
We did have a patient that we were able, nothing else was working. They wanted to amputate. And the patient ended up doing a little research and finding out, well, this type of infection is perfect for maggots. I don't understand why, doctor, can you not order me maggots? So she found a doctor who was willing to prescribe the maggots. And we at the Global PAD Association ended up buying the maggots
Oh, wow.
for this patient. They brought in a home care nurse, and she was able to properly deploy, like the technological term,
Little
deploy,
soldiers.
exactly, deploy the maggots. And within a few days, that wound was cleaner than I have ever seen any wound, and no amputation. Why is it? And this is probably a loaded question. Why is it that maggots are not standard therapy for for specific types of infections when they work so well?
Yeah, I mean, it's biological therapy, and I guess it's almost like the, yuck factor, that people don't like the sound of it, but then if they've tried everything else and like, okay, then I think it's psychological. And if the facility offers it, it's definitely a great option, because supposedly the maggot delivers some kind of antimicrobial, whatever, and as well. So it's not only cleaning up the wound, but it's also providing an anti-infective agent without us being, taking too many antibiotics or become resistant. It's another option in that regard as well. I think it's like leeches, like, people like, oh my God, it's bugs on me. It's like they do such good work when they're, deployed properly, but it's, I think, scary for people, I think.
It is scary, and then you also have to worry about, you need to make sure they're properly disposed of so they don't spread, right?
Right, exactly. Yeah, has to be done properly.
Bacteria either. So from maggots to let's talk about food. Are there any lifestyle changes that can help promote healing of arterial ulcers? And that is funny, we go from maggots and we are going to include food in this discussion.
Yeah, I mean, definitely nutrition, especially if you're diabetic. You want to keep your sugars under control. Otherwise, that's going to increase the risks of infection and what have you. And just, healthy foods, proteins, and the vitamins and minerals that are necessary for wound healing. Getting the
Mhm.
blood pressure under control, so limiting the sodium as far as that's concerned. Cholesterol, if that's high, that's, narrowing the arteries. So you want to get, hopefully, somebody watching your cholesterol levels and triglycerides and getting that under control.
I think
For
some people do underestimate the power of the diet in having a real time influence on wound healing. And
absolutely.
I love that you mentioned diabetes because that high sugar can really wreak havoc. I mean, that your blood becomes syrupy at that point when your blood sugar is high. And imagine this syrupy blood trying to eke its way through the capillaries to get to those wounds. And in so many cases, it's just impossible.
Absolutely, yeah, and it sets the stage for infection, and then you got all kinds of other complications, cellulitis in the leg, and and it's you've got one wound you're dealing with, and now you got more. So, and fungal infections on top of that, and it just gets very complicated with the high sugar. And
So,
if
what are
somebody's
the
anemic,
signs?
also, you want to get the anemia under control to get that, red blood cells carrying nitrogen. So that's important.
That's a good point. I haven't heard anyone bring that up before, that anemia. We have so many patients that are vascular cardiovascular patients that have anemia, and you always wonder, well, which came first, the chicken or the egg? I mean, is it
Right.
the anemia that drove the vascular and cardiovascular issues, or vice versa with some of the medicines that they're on? And it's a really tough call, and I think it works both ways, doesn't it?
Absolutely.
So, what are the signs of infection in an arterial ulcer, and then how is infection treated? And I would imagine that it would depend on the type of infection, of course, whether maggots are needed or whether a topical cream will do.
Yeah, so it depends. I mean, sometimes if you have such poor blood flow, you might not get the obvious signs of infection. The redness around the wound, the purulent drainage, the odor, the swelling. It might be very like subtle because your body, especially if you're diabetic, maybe not having that, immune response that somebody
Mhm.
healthier would have. So you're looking to see is the drainage changing? Is the wound bleeding a little more? Meaning that might be bacteria causing irritation. And it's
Right.
like, oh, the wound wasn't bleeding before. I'm not on any new anticoagulants. Why is it all of a sudden bleeding? Is it increasing in size? Um, that's a big one because, you expect a wound to be getting smaller, hopefully, or stabilize. Those are typical things, and you may see some swelling in your leg or have a fever, those sorts of things. But it's like sometimes a little subtle. You got to keep an eye on.
And left untreated, dot, dot, dot. What are
Yeah,
potential complications of untreated arterial ulcers?
I mean, your risk of losing the limb, unfortunately, I mean, major infection where you end up in the hospital, and God forbid, amputation.
Are there any new emerging treatments that you're excited about for these arterial ulcers that may not be available today?
Yeah, I've read about gene therapy. Just try to like help against that. I don't know details about it, but I was reading a little bit about to help generate new blood vessels and that sort of thing. So I was
Mhm.
reading an article actually earlier today. But that's exciting if there's a way to get new vessels in there to take over from the diseased ones.
Yeah, maybe that would help these arterial ulcers to heal faster. But faster, what does that really mean? How long does it typically take for an arterial ulcer to heal with proper treatment? And we've had patients end up. We had one that we just had healing 7 years. It
Oh,
took
wow. Wow.
finally heal.
Wow.
Of course, many a debridement, and there was, some bone left over in it, following an amputation, and oh my goodness. But
Yeah.
what, it could be as short as a few weeks to 7 years.
Yeah, I mean, I've seen a few heal in a few weeks if we get everything under control, not only just the wound topically, but get
Mhm.
that sugar under control. If there's edema, get that under control. Because if there's edema on the leg, it takes the cells forever to swim across to get to do their job with the wound healing. So that's why if there's a little arterial and venous together, but not so severe arterial that you can handle compression therapy, sometimes adding that on gets us over the hump and gets that wound healed.
Yeah, so some of those factors, again, that can delay healing of arterial ulcers, I think are worth literally just listing, high A1C, too much sugar in your blood, making it syrupy, of course, anemia. You were mentioning the edema can also lead to that. What am I forgetting?
If smoking, if somebody's a smoker, if the cholesterol's, elevated, if we try to, sometimes they say that it reverses some of the blockage from high cholesterol if you put on some of these medications, getting that under control. The anemia we said already, even drinking adequate number of fluids. So you don't want to be dehydrated when your blood is so thick.
Talk about how you know when you need a debridement for these arterial ulcers.
So by looking at the wound, if it's, yellowish color or, black and gray dead tissue, it'll need a debridement, not necessarily going under the knife, but the honey products help. There's other topical enzymatic debriding agents. And just by keeping the wound moist, not too wet, the body itself helps break down that necrotic tissue. If it has a lot of necrotic tissue, then a faster way to do it is sharp debridement, which I actually go to the house and do that depending on the situation. Or if it needs more extensive, then the surgeon will do it, depending on the situation.
So when
Both the
is
doctors.
surgical intervention considered for arterial ulcers? Now that we could take that two ways. One, you were just mentioned getting the surgeon involved for the debridement, et cetera, but also surgical intervention, meaning opening up of the arteries.
Absolutely. Maybe they could put a stent in there, or, just get that artery opened up. Use angioplasty, get a balloon to open up that artery. It's all kinds of interventions that can be done depending on the situation.
So who is most at risk for these arterial ulcers and how can they be prevented?
Well, definitely the diabetic patient, the patient with diabetes, those with hypertension, with history of peripheral vascular disease. The patient I came from earlier doesn't even have diabetes, so it just runs in the family. They all have had strokes. They've had, high cholesterol, hypertension, all these things the person may have with or without diabetes. And again, for a smoker, a sedentary lifestyle, maybe overweight, all these kinds of things, poor nutrition puts a person at risk. Neuropathy, for whatever reason, you're wearing tight shoes, you don't realize, and then now you're rubbing, and then you opened up an area and you have poor blood flow. And now here we go, down that road.
So the follow-up care, once an arterial ulcer has healed, what do you do?
Well, good, skincare, you want to monitor the area. Definitely have good fitting shoes and hopefully keep the lifestyle changes, keep an eye on that cholesterol, hopefully quit smoking if you're a smoker and getting the diabetes under control if you're a diabetic.
Yeah. Well, thank you, nurse practitioner.
You're
And
welcome.
any final thoughts on arterial ulcers, takeaways, for the folks that are tuning in?
Yeah, and sometimes they have that characteristic look, we used to call it like a punched out appearance, when you punch a hole in a paper. Sometimes they're a perfect round ulcer and it looks like it just neatly punched out. So sometimes that's a typical appearance. It could be on the ankle or the toes. Like I said, so it just, and we've healed them, just a matter of catching them early and hopefully with medication or an intervention that's needed if the blood flow is really inadequate to get the healing going on before we get to these, God forbid, gangrene or anything else.
And it's really important for patients to, anytime you have any sort of a wound on your foot, you should always get a vascular evaluation if you have any sort of risk factor, if you have even a family history of, or you have high blood pressure, high cholesterol, diabetes, even pre-diabetes, because even one sugar molecule could end up scratching those arteries and leading to that plaque buildup. If you were a smoker, former smoker, overweight, any of those, you really should make sure. And you know what? Even just being over the age of 50,
All right, there you go.
right? Because 1 in 10 people over the age of 50 can have peripheral artery disease, 1 in 5 over the age of 60. But even worse is 1 in 3 diabetics over the age of 50, even pre-diabetics, have peripheral artery disease. So if you are over 50, it's really important to always make sure that if you do have a wound that develops, to get a vascular evaluation and don't pass go, right, until you get it.
Absolutely. And sometimes too, patients will feel the pain at nighttime when the legs are up and they have to dangle the legs over the edge of the bed and that helps the pain. So that's telling us too, there's not enough blood flow going there or it's, inadequate. And then they have to get up in the middle of the night and dangle the legs. And when they raise the leg, it may turn almost like a pale color. And when they put the leg down, it turns reddish as the blood flow is being helped down. So, or if you're walking, you feel like, oh, I'm getting so much pain every time I walk. Might be something to consider and say, do I have, claudication? Do I have a problem with my vasculature? So,
Oh, you bring up such a good point. Oh, when you talk about prevention, yes, if you have any sort of family history, if you have any of these risk factors,
yeah,
even if you just have pain when you're walking that seems to go away when you rest, go ask your doctor for a proper vascular evaluation and ask them, do I have peripheral artery disease? Because more than 70% of more than 400 patients through the Global PAD Association's network that were polled said that upon presenting with textbook symptoms of peripheral artery disease, which includes you walk, you get a cramp, when you rest, the pain goes away. And that could be in your calf, it could be in your thigh, it could be in your buttocks
Right.
as well. It could even be in your hips. So many patients, more than 70% say that the doctor diagnosed them with everything else but peripheral artery disease and got them tested for everything else but. The top misdiagnoses include back sciatica issues, diabetic neuropathy. Too many diabetics are being brushed off as having diabetic neuropathy when it's actually peripheral artery disease, which is likely triggered by the diabetes. And there might be a little bit of both, but so many of these diabetics are allegedly asymptomatic until the point where they present with one of these arterial ulcers. And then you're really on deck for amputation at that point, and fewer options are available to open up those arteries and treat them. But we did have Dr. Craig Walker, who is a world-renowned interventional cardiologist and limb salvage specialist. His team was just named in the Global PAD Impact Awards as being the limb salvage team, global limb salvage team of the year. And he was saying nowadays that there are very few arterial issues that can't be addressed with so many new tools and techniques. And if one doctor can't get it open and puts you on deck for amputation, if your life is not on the line at that point, get a second opinion, get a third opinion, and find a doctor who is considered by their peers as a CLI fighter, critical limb ischemia fighter. If they're a critical limb ischemia fighter or CLI fighter, and always just use the acronym, just CLI fighter, they will know that they are one of them. If they ask you, well, what is that? They're definitely not one of them. So it's a really good indication that you do have someone that is going to exhaust all advanced efforts to try and save that limb and get that blood flow restored to the smallest vessels in the foot to get that wound, even on a toe, healed.
Absolutely. Wow.
So thank you so much, Nurse Practitioner Anne Walsh. We appreciate you coming on every single week. Any idea of what we might cover next week? I always put you on the spot in the end.
Suspense. Maybe skin tears might be an interesting one because we've seen a lot of those lately, some pretty severe with the arms, the legs, again, with, proper skin care to try to prevent them. As people are living longer and longer, the skin is susceptible to skin tears. That might be something interesting.
Fantastic. So next week, next session, make sure to join us. We're going to be talking about skin tears, which seems to affect everyone. So you don't want to miss that. In the meantime, if you want to learn more about wound care, make sure to go to the iPhone Apple Store as well as Google Play and download Woundcare Pro. That is Nurse Practitioner Anne's amazing educational app, and it can help guide physicians as well as patients. Even though it was designed for physicians and clinicians, we have had quite a few patients that have told us that they have downloaded it and found it really beneficial to create a more productive and satisfying conversation with their own wound care team. So make sure you do download that. And also, since Nurse Practitioner Anne Walsh joins us every single week, don't forget to like and subscribe to our channel at youtube.com/the way to my heart. Every week under the live tab, we make sure to show you the amazing array of physicians and clinicians that are available live each and every day to answer your questions, especially Nurse Practitioner Anne. So don't forget, like and subscribe to our channel, youtube.com/the way to my heart. And we'll see you each and every week.